from my learning, looking at what a code OB was, so at LHSC, a code OB, you call a lot of people. So if you call a code OB, you'll get the OB resident, the staff, the anesthesia resident, the staff, the OB charge nurse, and then the NICU resident, nurse practitioner, RN, RT, charge nurse, and also PCC residents, and you get the adult code blue team and CCOT. So if you call a code OB, be prepared for a massive descent of people into the emerge or the trauma bay. So before we go back to the case, I just want to talk about the incidence of cardiac arrest in pregnancy. So from the Canadian data that I'll present, it's about 8 in 100,000. And from the US data that I'll present as well, it's about 8.5 per 100,000. Just to contrast that to some of the US data that we have on some of the vascular catastrophes that we manage in the emergency department, aortic section is about 3, and subarachnoid hemorrhage is about 10. So it's not that uncommon that cardiac arrest in pregnancy occurs in Canada and the US. So let's start with the Canadian data. So this was data collected by a anesthetist in Toronto from the Canadian Institute for Health Information. So from 2002 to 2015. And they didn't really measure neuro outcomes. It was more of a retrospective data review. So out of 3.5 million hospitalizations, they had 286 cases of cardiac arrest. And 204 of them survived a hospital discharge, which is about 71%. If we compare this to the intra-hospital cardiac arrest data that we have in all patients, the survival to hospital discharge is actually quite good. So in all comers that have cardiac arrest in hospital, usually our survival is about 15 to 19%. Here we had 71%, so pretty good. In the table that you have below, sorry, there's a lot of information there. There are some of the common conditions that are associated with the cardiac arrest, not necessarily the cause. And you'll see that heart failure, antepartum hemorrhage, amniotic fluid embolism, sepsis, PE, or what they classified as obstetric embolism, are pretty common. Most of them have good outcomes or good survival to discharge percent. Probably a lower survival with our aortic aneurysms and ACS, but they're actually quite uncommon in pregnancy, just about 1%. Now compare that to some of the US data. So this is from the national inpatient sample, which is approximately 20% of all hospital admissions in the US. They had 4,843 cases and 59% survival to hospital discharge. And we'll go through some of the conditions that they saw commonly here. So their most common cause of arrest there was antepartum hemorrhage. They have a lower incidence of heart failure, pulmonary edema compared to us. I'm not sure what the exact reason for that is. We have less numbers, so maybe that could be a confounder. But again, amniotic fluid embolism, sepsis, VTE, ACS, all causes, and reasonably good survival rates, less so for the aortic dissection ACS. So this is the classic medical school slide on physiologic changes in pregnancy. I'm just going to talk about the two systems that are important to us in resuscitation, so the cardiorespiratory. So from a cardiac standpoint, usually in pregnancy, you have increased cardiac output. However, when the patient is lying supine, there is significant aortic cable compression by the gravid uterus, so that decreases preload and afterload, so you have a decreased cardiac output. And you have normally decreased systemic vascular resistance. From a respiratory standpoint, because of the gravid uterus, there's a decreased functional residual capacity. You have increased oxygen consumption, physiologic narrowing of the airway, and there's an increased aspiration risk. So in terms of our Resus priorities, as you probably know in medical school, the priorities are the same in terms of you manage the patient first, so mom over fetus. They usually recommend discontinuing fetal heart rate monitoring until you get ROSC, a return of spontaneous circulation. And unlikely that this would happen in the emergency department, but if the patient is on a magnesium sulfate infusion due to preeclampsia, you might want to discontinue the infusion and consider giving an amp of calcium gluconate empirically. So let's talk about circulation. So they previously used to recommend the hand position of CPR to be a little bit higher on the sternum for pregnant patients. There's not real evidence about which position for hand placement is better. So the American Heart Association went back and said the lower half of the lower part of the sternum, which we normally do for our other patients, is standard for pregnant patients as well. Again, class 2A, class C evidence. And let's talk about tilting or wedging the patient. In ATLS, we're taught that you can sometimes put a wedge under a pregnant patient to kind of decrease the aortic cable compression. It's a little bit harder if you're doing CPR. There's some studies to suggest that at a 28-degree inclination, which is probably the degree that you'll have in some wedges, you actually only get 80% of the compressive force when you're doing CPR. And the heart will also shift a little bit laterally, so it's unclear if you're actually compressing the right organ that you want to. So they usually recommend left manual displacement of the uterus. So you can have a one-handed technique or a two-handed technique if you have someone available like a medical student. And this is from some data from our anesthesia colleagues that were doing just regular C-sections. They found that with the manual displacement, they had less hypotension and less need for a push-dose vasopressor than even a 15-degree tilt when they were just doing C-sections. In terms of access, so because of the aortic cable compression, you do want to have access above the femoral veins, so you make sure you get the medication to where you want to. The defibrillation, you would use the same amount of electricity, and there's a theoretical risk if fetal monitors are still attached while you're defibrillating that you'll actually arc electricity, so they suggest removing the fetal monitors if you haven't done so already. In terms of the pad placement, again, expert recommendation is to place them in the same place that we normally would for our arrest patients, and then the same thing, we would use compressions after defibrillation. We would use the same drugs as usual, so in our non-shockable rhythm pathway, it would just be epinephrine. In our shockable rhythm pathway, you can use amiodarone as well. Amiodarone is a class D pregnancy risk, so there is evidence of fetal risk, but again, that shouldn't stop you in this situation. In terms of airway and breathing, as we know in our data in out-of-hospital cardiac arrest, we don't delay compressions to intubate. There's no improvement in outcomes getting an endotracheal tube versus bagging. In a pre-arrest setting, you may want to consider non-invasive positive pressure ventilation, and I'll talk about that in a little bit. It is a difficult airway, so you want to have the best operator available. They actually had some data in the Critical Care Medicine Journal in 2005 that failed intubation in pregnant patients was 8 times more common than a non-pregnant patient. And they will desat quite quickly because of the increased oxygen consumption, so you might want to have a backup plan, including a surgical airway. So now I want to talk about the resuscitative hysterotomy. It's also known as a perimortem C-section. Some of the emerged docs or experts will advocate for calling it more a resuscitative hysterotomy, because if you think about it, the goal is, primary objective is for the mom, so the mother's survival, not necessarily to get the baby out. So that's why they advocate calling it resuscitative hysterotomy instead. And the theory is to decrease aortic cable compression. Now, in what gestational age would this be reasonable? They typically would recommend over 24 weeks, but sometimes in an arrest situation, you may not know what the gestational age is. You may not be able to estimate it on your POCUS. So they usually suggest if the gravid uterus is above the umbilicus, which would be over 20 weeks, then that would be a reasonable thing to do, as that could cause some significant aortic cable compression. In terms of when it's recommended, so the American Heart Association recommends starting at 4 minutes and deliver the fetus by 5 minutes. And this theory was first promoted in the 1980s with not much evidence. It was more of a theoretical thought to get baby out, because if there was any complications, if there's arrest, then you'd have more fetal hypoxia after 4 or 5 minutes. So let's look at some of the data. There's not that much data on this subject. This is the biggest journal that I found, which is the Resuscitation 2012. And they did a review of all the data that was presented in English, French, Japanese, and German journals. And all of these are just case reports, case series. So again, no better data than that. And they could only find 94 cases that had resuscitative hysterotomy. So there is some degree of selection bias because they're mostly case reports, case series. And you'll notice that out of 94, they got ROSC in 57, so 60%, which is, again, pretty good. And we'll look at the location. The reason I show this slide is to show that some of these will occur in hospital, because they had a quarter of these arrests occur in the emergency department, so we would be managing these cases. The next slide I want to show you is the neurological outcomes. So thankfully, this paper did talk about neurological outcomes. In terms of cerebral performance category, it's similar to the modified Rankin scale. So a CPC-1 is a person that's able to lead a completely normal life. A CPC2 is one that's independent for their activities of daily living and able to work part-time in a kind of a sheltered environment. CPC3 is someone who's dependent for their ADLs, CPC4 is unconscious, and CPC5 is brain dead. So if you notice, out of the cases of ROSC, they actually had a pretty good number with good neurological outcomes, so almost 80%. 5 of them, they couldn't really quantify what the neurological outcome was, so they just said good. All right, so what about timing of resuscitative hysterotomy? So out of those 94 cases, they had 57 cases that reported the time from the arrest to the perimortem C-section resuscitative hysterotomy. And I just want to differentiate the surviving and the non-surviving characteristics. Again, it was about 50-50. And if you'll notice, the average time to the resuscitative hysterotomy was much shorter in the surviving group compared to the non-surviving group, about average of 10 versus 22 minutes. Although there are huge amounts of ranges, so you'll see that someone survived after 37 minutes of getting until they got the resuscitative hysterotomy. And what about the maternal survival? So they broke down the groups to less than 5 minutes, less than 10 minutes, or less than 15 minutes. And you notice only 4 cases actually had the resuscitated hysterotomy within 5 minutes. So some of the data, I'm not a statistician here, but some of the data they present was the area under the receiver operative curve as well as odds ratio. So odds ratio is a measure of association between an exposure and an outcome. So in our case here, a higher odds ratio will be better. So you notice that you still have good odds ratios with the best with less than 10, and still good odds ratios with less than 15. And in terms of the area under the receiver operative curve, which plots sensitivity over specificity, you want something close to 1, because that would be perfect. And we had 0.827, so it's a pretty good area under the receiver operative curve. In terms of neonatal survival, again, good odds ratios with less than 10 minutes, and a little bit less so with less than 15 minutes, and a still good area under the receiver operative curve, but not as good with maternal survival. And unfortunately, we don't know what the neonatal neurologic outcomes are from these studies. So before I show you a video on the technique of the resuscitative hysterotomy, I just want to talk about a caveat, and that is, in most centers, especially in some place like London, I don't see myself initiating a resuscitative hysterotomy, because we have obstetricians, surgeons in-house, that they're probably the more expert in the situation to do it. However, if you are working in a hospital that doesn't have obstetrics in-house, or they're unable to come within 5-10 minutes, this is something that I think that we should be aware of. I think there's a big cognitive barrier in initiating this, similar to our surgical airways. So you might want to prepare the team, you might want to mark the belly, and you want to have all our help available, because when you do this procedure, you'll probably need some resuscitation of the newborn as well. So you want to have our pediatric colleagues involved. So I'm just going to get the video loaded. So this is a very high-fidelity sim model of the resuscitative hysterotomy. And I'll describe the technique as the video plays. So first, before we start, some of the obstetricians will recommend discontinuing CPR just for the skin incision, because they recommend starting at the xiphoid. So if the hands are in the way, you don't want to cut there. So some people recommend stopping compressions, or you can continue. So what this person does, oh, sorry. So what this person does is he starts with a vertical incision, goes down to fascia, they bluntly dissect the rectus there, and then they make a vertical incision on the uterus. Now, our obstetrical colleagues will probably be making a transverse incision because they're more comfortable for that, but I think for us, if we're going to do it, we would just be cutting vertical. They deliver the baby, and then they clamp the umbilical cord, and then they hand it off for the baby for resuscitation. I will say that at this point, you can deliver placenta and you can sew up that'd be functional. So some people recommend just packing the belly with sponges, and then later So if the patient does get ROSC after the hysterotomy, they're probably going to have pretty severe postpartum hemorrhage, just because you'll have a pretty floppy atonic uterus. So again, they'll need more definitive management after this maneuver. And in the case that we had the resuscitative hysterotomy, they just packed the belly. Okay. So what's equipment required for this maneuver? American Heart Association, these are the lists of equipment that's required. I didn't know what a Russian forceps was, so it's this fancy forceps here. I think in terms of equipment, we have all we need in a laceration tray, plus we need a number 10 scalpel. So basically you just need some clamps, scissors, gloves, and a scalpel, and that's really all you need. And what about post-arrest care? So we don't use targeted temperature management now commonly in our ROSC patients, and there's no real data in pregnancy. So there's 2 case reports that I found that of patients who did not have a resuscitative hysterotomy, they had targeted temperature management and they did well. But it's hard to say if this would be an option after you do a resuscitative hysterotomy. So the American Heart Association recommends may be considered class 2B or class C evidence. The problem with targeted temperature management is if you lower the temperature, this can worsen a coagulopathy, and coagulopathies are quite common in our postpartum hemorrhage or pregnant patients. What about some of the other tools that we can use during arrest? So this is a picture of Dr. Arntfield. As Aaron and Frank discussed 2 weeks ago, you can use the transesophageal echo as a way of looking at the heart while CPR is ongoing. As I can imagine, doing a transthoracic ultrasound in a pregnant patient would be quite difficult, especially if you're trying to go subxiphoid. And we'll talk about one of the pitfalls of doing an echo during the arrest in a pregnant patient later. But I want to talk about ECMO briefly. So ECMO is kind of the hot new topic in terms of our arrest. Not very common in Canada, but some in Europe and Australia, they're using it commonly for arrested patients. And there actually is case reports of 45 pregnant patients who did undergo ECMO. Most of them were from ARDS, secondary to influenza, H1N1 in Australia. But actually one of these patients had ECMO intra-arrest. So they had a hypoxic arrest due to a pulmonary hemorrhage, and they had ECMO initiated 45 minutes in. So no resuscitative hysterotomy. They were continuing CPR for 45 minutes until they were catheterized and placed on ECMO. And this patient survived neurologically intact. They had a pretty good survival rate for patients placed on ECMO, so about 78%. And this was presented in the Journal of Thoracic and Cardiac Surgery. So I think it might be out in the future in the horizon for us, but not at this point, especially since our ECMO center seems to be at University Hospital. We can't really transport these patients there. So now, after talking about the arrest itself and the resuscitative hysterotomy, I want to move on to pre-arrest specific management of some conditions. So first off, heart failure and pulmonary edema. Not all pulmonary edema will be related to heart failure. Actually, 10% of severe preeclampsia can present as pulmonary edema. The management would be a little bit different, but I want to talk about general principles. So what about non-invasive pressure ventilation? Theoretically, people would worry about an aspiration risk, especially in a pregnant patient, for non-invasive positive pressure. But there are some case reports that it was helpful in pregnant patients. So there's 4 cases of sickle cell disease, pregnant patients that had acute chest syndrome, and it actually spared intubation in all 4 of them with non-invasive positive pressure. You can use nitroglycerin in terms of an infusion to treat the congestive heart failure, and you can also use furosemide. They're class B and class C pregnancy risk. If the pulmonary edema is due to preeclampsia, so you can treat them with magnesium sulfate, and they'll usually need definitive management, which is delivery. In terms of antepartum hemorrhage and trauma, there's not much for us to do about it. Basically, there's the main causes are placental abruption or placenta previa. From our perspective, we would be giving them blood plus or minus tranexamic acid, and they'll need definitive management from our obstetrical colleagues. So same thing with trauma, our ABCs, blood, TXA. If you can, identify a source of bleeding and get the appropriate service involved, and then if they're unstable, they'll need definitive management. So we actually had a case about a month ago, Alex and I. So it was a 20-week gestational age. She was riding a bike and was hit by a car and had pretty severe splenic lax. So she had free fluid in her pelvis. And because she was stable, she was sent to the CT scan and eventually was sent to IR to embolize all the splenic lax. Now, I do want to spend some time talking about the amniotic fluid embolism and the pulmonary embolism. So, in terms of amniotic fluid embolism, if you remember the data that I had earlier, in Canada and the US, it's approximately 13% of arrested patients. And it's basically, in terms of the pathophysiology, it's entrance of fetal material into the maternal circulation, causing this inflammatory response, kind of like SIRS. And most of these cases will occur during labor, so about 70%. And usually they present with sudden hypoxia, hypotension secondary to right ventricular failure, followed by a coagulopathy. In terms of the guidelines, so the Society of Maternal Fetal Medicine, they recommend considering resuscitative hysterotomy, doing the normal CPR as we would do, and you can't really use targeted temperature management in these cases as they would be in DIC. And I want to differentiate that in pulmonary embolism. So first off, thrombolysis is safe in pregnant women. There's a review article of giving thrombolytics to pregnant women. 25 of them had a PE, and 13 used TPA that we would use for our massive PEs here, so alteplase. They had 3 major bleeding complications and 2 causes of moderate hemorrhage, so maybe a little bit increased risk of bleeding compared to our normal thrombolysis candidates, but it's still safe to use. The reason I want to differentiate amniotic fluid embolism and pulmonary embolism here is that if you did an echo on them, they would have similar RV findings as amniotic fluid embolism. So they could have a dilated RV, they could have poor RV function, and could have some septal deviation. So unless you're quite sure that this is a slam dunk PE, like they have coagulopathy, they have casts on both sides, or they arrested just after the scanner that shows a saddle embolus, I'd be a little bit hesitant to thrombolyse this patient. And if you do thrombolyse this patient, you can't really do a resuscitative, or you could do a resuscitative hysterotomy after, but it'd be quite bloody. So let's go back to the case. So she was resting in the CT suite, she was wheeled to resus, a code OB was called, standard ACLS protocol was initiated, including epinephrine. Since our obstetrical colleagues were in-house, they came right away. A perimortem C-section was done within 5 minutes. The baby was delivered, Nikki was there to resuscitate the baby. And while they were doing the resuscitative hysterotomy, they actually encountered significant blood in the abdomen, maybe from the spleen. So they suspected a splenic artery aneurysm, so they called for a massive transfusion protocol. So if you call for a code OB, you won't get any blood. So if they're bleeding, you want to get a massive transfusion protocol. And what is the incidence of splenic artery aneurysms? Because I haven't really heard about it before this case. It's very rare. Any kind of visceral aneurysm is less than 0.1% prevalence, and many of them are asymptomatic. So it's unclear how many of them actually rupture. So they did get ROSC after resuscitative hysterotomy, but unfortunately then had a PEA arrest. Again, ACLS protocol was continued, and they did consult cardiothoracics for possible ECMO for this patient, but unfortunately, because they couldn't get ROSC and no one was here to catheterize the patient, they couldn't really transfer him. So unfortunately, the pregnant patient did not do well, so she passed away. But last I heard, I think baby was doing well. And I'm not clear how much blood products was given to the patient at this time. So I want to summarize. So maternal cardiac arrest is quite uncommon, but some of them will present to the emergency department. The survival and neurological outcomes from these patients are significantly better than our typical arrest population. In terms of circulation, you want to use the same compressions and the same rates and depth, but adding the manual displacement. And I want to talk about considering resuscitative hysterotomy 5 to 15 minutes and ways that we can overcome that cognitive barrier. So if there's an arrested patient, we can talk about letting the team know in advance, marking the belly, etc. So these are my references, and I'm happy to open the floor to discussion or questions.
question. Well, thanks a lot for that. I think having been in a simulation setting for this, the Insight sim, one of the biggest realities I faced was primarily crowd control, right? This is a very emotionally charged thing for arguably any physician, regardless of training background, to then come down into the trauma bay and try to navigate through horrible emotions and the patient's physiology. It's quite challenging. And really, you need 4 separate teams, right? And as you very adequately pointed out, you're going to get sometimes 30, 40 people that are going to rise to this situation. So really, crowd control, I think, is something that we primarily optimize in the future. And reflecting back on that actual case that occurred, the notion of cross clamping in an aorta in this setting, when you have an open belly, is something that I think potentially we consider if it happens again, because that would prioritize blood flow cardiac output. And then the question I have, and is really for anybody in the room, I don't really see a role in doing this in a peripheral setting.
Oh, what's that?
In a peripheral setting, where you don't have OB, you don't have general surgery, you have yourself and maybe 2 nurses. It's an awful situation to be in, but from a resource allocation perspective, this is somewhat similar to doing a resuscitative thoracotomy, where if you don't have a thoracic surgeon or a trauma surgeon who can lift this patient away, you're really starting something that you can't finish.
Right.
So I'm curious, I don't know if I was in full counties if I would pull the trigger.
Right.
Andrew, I couldn't agree more with you. Even if you look at a hospital like Woodstock, which has the spectrum of general surgery, they don't have pediatrics. So their challenge there, they could potentially do this there, but they would be pushing it. In most of the 27 hospitals in our limb, this is not. Maybe in Old Sound, Stratford, Woodstock, St. Thomas, and London. That's about it. Simply don't have the backup actually in-house. And if you do a procedure like this and you've never done one before, if anything goes wrong, you're hung out to dry. You're essentially practicing outside your specialty.
Right.
If you want to do this, you need to spend some time in obstetrics. You need to participate in some normal C-sections. So you see how it's done, see the techniques, you gain some experience.
Dr. Corbin?
First, just to get your comments, I agree with Dr. Paul, very important. And I have to say that the code itself is managed extremely well. If there were a ton of people there, it was very well organized, very well integrated. It was done as well as it should be done. In terms of the cross-secting of the aorta, absolutely. So once we evacuated the uterus, we actually wrapped the aorta to close it. That's when we got the patient briefly back. But unfortunately, she had no blood in her, so she had nothing to hold for it. And then in terms of the resuscitative hysterotomy outside of our centers, I agree it's a difficult situation. I don't think that there is a way that emergency trained enough that they would feel comfortable doing a cesarean section, but it would be a Hail Mary sort of situation in terms of attempting everything, depending on where the emergency how far they were. In a situation like this, it was not a concern about closing her uterus, because she was not receiving that from her uterus. So in looking at every attempt in our ability to try to resuscitate this patient, that's something that we should consider. But there's not going to be a way for emerge in a tertiary care center to have an uncomfortable cesarean section of the patient.
Forward fire we built the code of based on experience with patients in CCTC, where we had to prepare for a fairly certain cardiac risk and discovered many things that I think are fixable in small hospitals as well. As for the comment on what do you do in a peripheral center, simply then you do, then you don't, right? Because it's a resuscitation, it's most helps circulation. Maybe you should be less afraid. I mean, you do the midline incision, you do midline uterine incision. If you can pluck that placenta out and then see where you can compress the uterus until someone comes and helps you close. Any hospital has general surgery.
every hospital is not.
We get babies delivered from Hanover.
There are OB centers that have done surgery, but many hospitals in the other three do not have done surgery. Most of them do not have done surgery in-house. And most of them are, as Curtis described, one doc, one or two nurses.
Yeah, no, I realize that, but I think part of the evidence, and I would love to hear your opinion about this, is how big is the role for resuscitation. And so that is what our guys say, you should really consider it for, first of all, internal circulation, and for that, it doesn't really matter that much how much that is doing. It's what you should do for internal circulation. If that's a classical or not, the photo key things that we discovered is, for instance, the knife. The knife is a knife that needs to be put on a handle that is significant delay in time. So whenever there's a patient at high risk for an echo, there is a knife, a disposable knife, taped to the wall. Many of the C-section sets in hospitals where there are obstetrics have a little ring on the top of the tray that gives them the essential instruments for a crash. So we need to be ready to unpack the tray, get our essential instruments. And so they grab that ring, that's what they need for a crash cesarean. So those are things that may exist in hospitals. Russian forceps, never heard of it. So I don't think you need anything but a knife and then a tray to come. Yeah. You have that. And so the code OB gets you in our hospital, the obstetrics and nasal. Please don't call the code OB for delivery. That's not what it was intended for. So everyone comes running and abandons the code because often both of the patients that are in-house and the residents. So yes, you do get crowd control. The purpose of that is that whoever is available first will come, and then we'll allocate the second people back to the delivery to manage the rest of the So there's some things that have been set up. That's the normal code get left. Not either, right? So there's no code at all that is different, but because we feel that that's the issue, and that might be something
So I just want to summarize some of the comments briefly before we move on. So basically some of the good points brought out, thank you for your comments, was that should we consider this in a peripheral center if we don't have obstetrics or surgery in-house or backup, because it's kind of similar to resuscitate a thoracotomy, like what is our end goal? Because they'll need definitive management, and if we don't have that, why are we doing it? So I'm an N of 0, so I don't really have physical experience in this area, but I was thinking for resuscitative hysterotomy, it's a little bit different than a thoracotomy, that if you have an obstetrician in-house or a surgeon that they could easily kind of close the uterus, close the belly, it's a little bit different than a thoracotomy where you have to have a thoracic surgeon or a trauma surgeon. So I think in a smaller hospital like Woodstock, if there's an obstetrician in-house, then this could be something to be potentially thought about. The technique, not that I've done one, shouldn't be technically too difficult because you're just making vertical incisions until you get to baby. So that's my personal 2 cents on that. And then some of the other discussion was kind of centered around what other equipment is needed. So they basically suggested just the scalpel and some tray with some forceps and towels. That's all really you need in the situation.
So we're looking at stepping from the total weight that we usually see now it's PHY, that's OB and scribing and other numbers. We're looking at developing total weight for University Hospital. You can imagine most of us in the 4 a.m. internal coverage of UH, this would be one of the cases that we would be extremely anxious about doing. The current process after our most recent meeting is the expectation is that we would do as a weekly doc, and likely is do the resuscitative hysterotomy. At the same time, when page goes out, 2 OB is looking
likely on the phone with us talking us through the NICU team and organizing transport. They come and they get 90, they're getting general surgery there. So it's in the infancy at University Hospital, but that is in the university. Make us all cringe and really happy.
I think too, just to make sure that I didn't misrepresent. Those of you that know me, I'm pretty aggressive in the resus phase. If I was anywhere close to a hospital that had something surgery within 5 minutes or half an hour for that matter, I'm doing this. But if I'm in the middle of Northern Ontario and I've got 6 patients and 1 nurse, it becomes an ethical dilemma of, well, these 6 patients who are still alive and we're dying of sepsis that I can manage versus something that you can't transport in a hospital 300 kilometers until they get to the nearest center. So, yeah, sorry about that.
Sure.
I think just finding that I don't think we make a blanket statement about a peripheral hospital and tertiary site. Depends on the time of day. Peripheral hospital in the middle of the afternoon may have a full complement of people that you need it would be reasonable. UH at 4 in the morning may have very limited. So I think it's reasonable awareness of what we have.
Oh, I just wanted to comment briefly because Dr. Dreyer brought up kind of the medical legal aspect of things and if you would have any backup. So just from the guidelines, so the American Heart Association and the Society of Maternal Fetal Medicine, they both say that there's really no harm in initiating a resuscitative hysterotomy. So not that I'm an expert in medical legal, but I think you'd be backed up by the guidelines if you do initiate that because again, it's kind of a Hail Mary situation. There's already dead, so you can't really do much worse than that. So I think you'd be backed up in that perspective.
Road trip, and you try to do something like this. There's nobody there. This is in London. So I think, and don't get me wrong, and I agree with the treatment platform that when push comes to shove, you're the one who's got to do it. But definitely, I don't look forward to ever being in that situation, but I think from a medical legal standpoint, I think the patients that, you're not really going to get someone that. I think it's actually good people. It's not. I'm not
Yeah. There was a point that the code opens for cardiac arrest in pregnancy. Is there an institutional protocol for labor coming in terms of how it's supposed to call for help for that?
So I'm just going to repeat the question. So the question is, so CODA B is usually for cardiac arrest in pregnancy, but what about if there's a patient in labor, like in the emergency department? What do we call for that?
We're in that we had the call of CODA B. I did delivery in the CCTC with the entire team of people. I told the CCTC nurses 3 times. I could deliver the baby, it's going to be okay, and they called the CODA B because we were outside of the delivery room. So they misunderstood the concept, what we were doing, and then the entire extra 30 people came and said, you're here, it's a vaginal delivery, what are we doing here? So they kind of get extended. The CODA B is meant for this. It is meant for a very critical event. And if somebody thinks that it is a very critical event that may lead to patient significant compromise, you call the whole team. But for a vaginal delivery with otherwise normal weight, just call it from the company. We've actually had a resident significantly injured by somebody calling it CODA B in the parking lot for a woman.
I think from a practical standpoint, from an imminent delivery, you might ask the switchboard to page the staff and the resident, and have one of your nurses or clerks actually have the discussion and tell them it's an imminent delivery so you can pay attention to the patient. And at the other call you can make is ask them to call OB triage and tell them directly the delivery happening in the emergency department so they can run it.
So I working in the auto hospital, they actually had a code that was for delivery outside of the delivery room, which was code 555, and then they had code 333 for internal cardiac arrest. So there was a separate code, and it was very clearly like everyone was on the same page about that. So we knew if this code was called, you just need a second because there's a delivery happening somewhere in the parking lot or elsewhere, and if they called this cardiac arrest, and these are the people you need. So if it is that unclear, then maybe that's something worth talking about.
I guess you could call ministry separately because that would go together. Someone else that I would want in a room in this person.
So what would happen if you, I think, just call one consultant, the consultant on call will come over and will initiate a treatment. So we react, our only charge nurse in the delivery room is the one who coordinates. So that's the first number I would call. If it's not called from the nurse or from anywhere else in the hospital, I call my charge and I say, I'm on my way to there, there, and there, because they say there's someone delivering. And they'll send the nurse, delivery says, and the NIC. So it's actually fairly simple, as long as you get
I just want to briefly touch on the comment that what if you don't have pediatrics in-house to manage the baby? So, I mean, it sounds like we have baby warmers at UH, and I'm not sure at Vic in the emergency department if we have a baby warmer nearby, but really, in terms of the principles of neonatal resuscitation, you have to warm, dry, stimulate the baby, and if needed, if their heart rate is low, is positive pressure. So I think that's within our scope of practice if we have our hands available to resuscitate baby as well. So I don't think that should be a deterrent, potentially, of doing the resuscitation hysterotomy, just my 2 cents.
It's also not the aim.
Right.
So so that shouldn't be, you do it from a general information. And if baby really needs incremental resuscitation, you have to know that after 5 minutes.
One more question. Do they come across any literature suggesting use actual post-resuscitation drawing? Because those seem like two separate topics. You really didn't happen to on it.
Yeah, so the question was, is there any cases of patients who had a resuscitative hysterotomy and then going on to ECMO? Unfortunately, the only data of someone who was who had an arrest and was on ECMO was that one case report, so I couldn't find anything else on that. I wonder if in the future that's something they'll consider, but not sure.
Yeah, they become once the patient that you wanted to improve. Patient that had a severe CPR for 90 minutes while we waited
So,
it was a
So it sounds like there's one case who had a cesarean section, arrested PEA, and after 90 minutes is when they initiated ECMO. Do you mind talking a little bit more about that case? Like, what was the specifics there?
She came in with shortness of breath, 37 weeks, and had a massive bilateral travel pulmonary embolism that was not initially recognized. She was brought in for fetal monitoring, membranes ruptured, and then she had a significant fetal heart rate elevation, so she was intubated for a crash and infection and was delivered on pretty fine. She then went into PEA arrest. Just within her abdomen, and CPR was initiated as a code. She had CPR for a total of 90 minutes, 45 of which were while we were awaiting the embolism to establish access. And there were a couple of points where there was discussion of whether or not it was mild, but given that she had been following CPR and wasn't breathing, and she was put on ECMO and did survive. Eventually, home.
Do you know what her neurological outcome was? It sounds like pretty good.
Yeah, I don't know what she was like before.
Right.
Fire pressure now.
And I guess one question that I had while I was preparing this presentation for our obstetrical colleagues is, do you have any advice on how to better differentiate an amniotic fluid embolism versus a PE? I mean, it sounds like it's more, based on the history, but it's kind of hard to differentiate because we don't really see this in non-pregnant patients, obviously.
But it's like echo.
Right.
The sequence of the first the pulmonary cardiac complication along with study on physiology.
Okay.
So literally they look at these small little orifices like as soon as they have a decomplication. So it's a little bit
Right. Right. Because that'd be helpful for us, I guess. If they're bleeding from a lot of places, you wouldn't thrombolize them because that wouldn't be a PE. Yeah.
Specifically in the context of the liver. Yeah, so virus and variant infection is more common in these settings. You can be infected in the liver as well, but it's in the context of the liver.
So,
The fluid is exposed to the vessels, that's how it is with the circulation. And then that's off the cardiac phase and then the
so the question was, in what context would we see an amniotic fluid embolism? And I did review the slides of Dr. Schmidt, and he suggested that if the patient for somehow ruptured their membranes before they went to the emergency department, so they had some membrane rupture, then it's possible that they could have that embolus, so that's when we'd be thinking about it. So it's not uncommon that we might see this.
In addition to trauma, by the same mechanism.
And the comment was trauma, you might get amniotic fluid embolus as well. Any other questions? All right. Thanks, everyone, for participating.